So today I'm going to talk about anticoagulation and hemostasis in urology. And I've noticed about 50% of the audience is lost when you start with an objective slide, so I'm going to start with a case instead. So Mr. Albert, he's a 76-year-old male. He's had 4 days of gross hematuria, and he comes to emerge with retention and clots. And he has atrial fib, for which he's on apixaban, and he has quite a high CHAD score of 5. He had a TIA in 2013, hypertension, diabetes, and coronary heart disease. So for any current residents, Mr. Albert may be a source of frustration, especially in emerge, and it may even strike a nerve. So you see these terms like apixaban, retention, emergency, clots, ASA. So my goal today is to sort of break down these terms and perhaps shed some light on perhaps apixaban. So we'll start with coagulation cascade. Everyone knows it has an intrinsic and extrinsic pathway meeting in a common pathway, ultimately activating fibrin. And these cross-linked fibrin forms a mesh atop a platelet plug that completes the clot. So this can be a surgeon's best friend while in the OR, but this is a target for drugs for those patients that have clotting problems. So we all know warfarin. It's been around since the mid-50s, and it inhibits the vitamin K-dependent synthesis of factors 2, 7, 9, and 10 by inhibiting vitamin K epoxide reductase. So by inhibiting this enzyme, it indirectly leads to its anticoagulant effect, an important concept for later. So it was approved by the US FDA in 1954. As you know, it's dosed once daily, titrated to an INR of 2 to 3. And its onset of action is very slow, 4 to 5 days, and its half-life is 40 hours. But it's safe in our patients with compromised kidney function or end-stage renal disease, so it's used in these patients. So what about a new class of medications? In the year 2010, a new class called the novel oral anticoagulant, or the non-vitamin K oral anticoagulant came out. There's various terms for them: target-specific, oral direct, specific oral. They had a bunch of acronyms, but at the end of the day, they settled on direct oral anticoagulant. I spoke to Dr. Erica Peterson in hematology, and she's in the know, and she says that this is the term that they use. So the first to market was DABIGATRAN or Pradaxa, and it's a direct thrombin inhibitor. It's the first medication in 56 years in an oral form that actually targets one of the factors in the cascade. So it's known as Pradaxa. It hit the market in 2010. It's BID dosing, and there's no lab monitoring, so very convenient for patients. Onset of action is very quick, 1 to 3 hours versus 40 hours for warfarin, and it has a relatively short half-life, about 14 to 17 hours. But it's renally cleared about 80%, so that's different from warfarin. So it's contraindicated in people with a GFR of less than 30. And 2 years ago, an antidote was developed, adarizumab. The next class of medications of the DOACs are the 10A inhibitors, and they directly competitively inhibit factor 10A. And if you notice in the names of all the drugs, they have a 10A right in the middle of it for memory. So the first of them was RIVAROXABAN, and it's an oral factor 10A inhibitor. It's known as Xarelto. It hit the market in 2011, and it's once daily dosing with no monitoring. Onset of action is 2 to 4 hours, and the half-life is 7 to 11 hours. It's renally cleared 33%, and there's no antidote yet, but they're in phase 3 studies of an antidote, and Dexanet alpha, which is actually a modified recombinant factor 10A molecule that's catalytically inactive when bound by other clotting factors. So it acts for a sink for the drugs. The other medication which Mr. Albert is on is apixaban. It's also a 10A inhibitor. It's marketed as Eliquis, and it hit the market in 2012. It's BID dosing, and there's no monitoring. Quick onset of action, half-life is 8 to 14 hours, and it's renally cleared 27%. And adexanet alpha also works as an antidote, and they're in phase 3 trials. So within the last 5 to 6 years, we've added the DOACs to the options for oral anticoagulation. So we have warfarin, we have the 10A inhibitors, and the direct thrombin inhibitors, dabigatran. So this is a table just summarizing, and I think the key points are the quick onset and relatively short half-life of these new medications, the fact that they're renally cleared, so we have to keep track of our patient's GFR, and they're actually contraindicated if it dips below 30. And there's no lab monitoring, so no INRs, and less frequent drug interactions versus warfarin. So how have these medications been prescribed over the years? In 2010, there was no competitors, and then dabigatran came along. And about a year later, they shared about 50% of the new users. And in 2011, RIVAROXABAN was introduced, and now has gained about 50% of patients starting on oral anticoagulation. So some people think it's the once daily dosing for the Xarelto uptake, but it could be effective marketing with Chris Bosch and Arnold Palmer, rest in peace, and Kevin Nealon. So how do these drugs actually compare in the trials? There's 3 large trials in AFib, and these DOACs show similar or lower rates of ischemic strokes and major bleeding, even though there's no antidote. And they have less intracranial hemorrhage. Plus, they're convenient. There's no INR testing, no dietary restrictions, and very few drug interactions. The cons being lack of efficacy, safety data in patients with chronic kidney disease. It's very difficult to monitor levels and compliance, so there's no test for INR, but that sort of keeps our patients honest. So you don't actually know if they're taking the medication, and a relatively higher cost, about $100 to $150 per month for these medications.
And if you do have chronic renal disease, and does this drug accumulate?
It does, yeah.
What effect does that have then?
There's relatively low data, but they're actually, like in acute kidney injury, it does accumulate and it's very difficult to clear, and it can augment the bleed. And dabigatran is actually, you can dialyze it off, but you're told it's actually a contraindication in prescribing it to those less than 30. So the higher cost is sometimes an issue. Also, people stay on warfarin if they've been on it for years. They're well controlled. They do an INR every 3 weeks. They're pretty regimented in their diet and what they can have, and they're very well controlled, and they don't see the use of coming off of it. So let's do a quick medicine detour.
Ben, did you say it was less intracranial hemorrhage on warfarin?
Yeah, no, on DOACs.
Oh, on DOACs.
Yeah, across all studies.
So it's better to get off the warfarin.
Yeah, that they do. When I was talking with Dr. Peterson, if they've been well controlled on warfarin, they do present, new options, and they say, they encourage their patients to come off of it.
Is hypertension and a contraindication to prescribing?
No.
Like severe hypertension?
No. Obviously, that should be addressed and
Right.
controlled, but no. So the Canadian Cardiovascular Society came out with new guidelines last year, and that anyone over the age of 65 with AFib, they recommend starting on an oral anticoagulant. And those patients that do have to start, they actually recommend a DOAC. So, when I think 65, I think BPH, our bread and butter patient, or other patients. So we're going to be seeing more patients on these medications. And even if you're under 65, if you have any of the CHADS2 risk factors, they recommend oral anticoagulation. So this may, impact our practice that these medications would be more prevalent. So what happens when a patient comes to emerge like Mr. Albert or worse, or a GI bleed or intracranial hemorrhage, and they're on one of these DOAC medications? Looking into the literature, it's actually mostly supportive. Because this medication doesn't linger that long, you just simply hold it and wait the 1.5 to 3 days, the 5 half-lives. You follow PTINR, PTT, thrombin time, which can be used in DABIGATRAN, platelet, and transfused PRN. You can give an antifibrinolytic agent, but this would be contraindicated in gross hematuria. And for major bleeding, where the patient is unstable or requiring lots of transfusions, it goes right back to ABCs, invasive monitoring. And when I was chatting with Dr. Peterson about this conundrum of, there's no antidote, well, she reminded me that bleeds come from a hole in a vessel, and that these medications make that worse. But ultimately, if they can have upper endoscopy for a rapid GI bleed, that has to happen in parallel with all the other things you're doing. So at the end of the day, you don't rely on an antidote. You should address the source of the bleed if that's what the patient needs. They also give octaplex or inactivated prothrombin complex concentrates, and this is a combination of factors 2, 7, 9, and 10. But this is no free lunch. Patients have a 1.5% chance of having a clotting event when they give this medication. So as I said before, there is a reversal agent to DABIGATRAN. It's marked as Praxbind, and it's given in life-threatening bleeding or truly emergent surgery. So back to Mr. Albert. He's admitted to urology for CBI. His apixaban is held. His hemoglobin is followed, and eventually it stabilizes. His urine gradually clears, and CBI is weaned. He started cautiously on dalteparin prophylaxis, and then up to his apixaban. Luckily, his urine still stays clear, and he passes his trial of void and is discharged. So the question is always, should he be worked up in our, urology rapid access clinic for his gross hematuria, even though he's on apixaban? So a few retrospective studies have looked at this.
So I assume he got worked up for his hematuria. There's no mention of it there. He just got sent home.
Yeah, so the workup's coming. Sorry. So yeah, he should be worked up. A few retrospective studies have looked at this, and they find urological disease about 20 to 30% of the time. And in one study where the INR is well controlled, 55% of the time. So obviously he goes through the usual workup he's seen in clinic, and he undergoes cystoscopy. Thankfully it's normal, there's no bladder tumor. And his apixaban is continued for cystoscopy. And I did some digging, and I said, what other urological procedures can we perform safely while these patients are on their anticoagulant? And the list is small. Obviously cystoscopy, ureteroscopy, and laser lithotripsy, if needed. So you're always weighing the risk of clotting versus the risk of bleeding. Photoselective vaporization of the prostate or green light laser is quite safe. There's been lots of studies on that. And holmium laser is technically feasible, but the one study I looked at showed a 10% transfusion rate and delayed discharge, delayed removal of catheters. So it sounds like it wouldn't be the best option, but it is technically feasible. So looking a bit more at green light, there's been lots of studies, all retrospective, ranging from 18 to 500 patients, and none required perioperative blood transfusion. And when they tracked how they did long-term, they did the same. They had similar improvements in IPSS as to those patients not on anticoagulation. So it's not like they had half a procedure or the procedure was aborted. They had durable results. So all the authors of these trials concluded that it's safe and effective for those that must stay on their anticoagulation. So Mr. Albert has a CT, and unfortunately we find a left posterior renal mass. His GFR is 70, so he's motivated to have nephron-sparing surgery. So he's booked for a partial nephrectomy. So I know everyone's wondering, should it be open or robotic? Dr. Gleave, any comments?
Probably robot.
Okay, so why don't we talk about the perioperative management of these DOACs? So they're short half-life, therefore bridging of these medications is not required. And post-op, due to its rapid onset of action, DOAC should only be restarted once hemostasis is achieved. So this is from the VGH peri-procedural recommendations, and they recommend holding these medications for 2 days if it's a low bleeding risk, but anything in urology is considered high bleeding risk. So these are held for 3 days. And that makes sense because the average half-life is about 12 hours, and 5 half-lives would be 60 hours, so they're erring on the side of caution there. What if the patient was on warfarin? So this is their list. If any of the patients have these conditions and they're on warfarin, they recommend bridging. So anyone with a mechanical heart valve, who has rheumatic heart disease, atrial fibrillation with high CHAD score, recent stroke, TIA, DVT, or PE in the last 3 months, thrombosis while their anticoagulant was interrupted, or a history of severe thrombophilia. Because AFib is so common, I thought I'd dive in that they left CHAD scores 1 to 4 off this list. And they addressed this question in the BRIDGE trial, which came out in 2015. And it's for patients with AFib who need interruption of warfarin for an elective operation. And they randomized 1 to 1, a large trial, around 1,900 patients. But the limitation of this trial was that the mean CHAD score of the patients were 2.3. So they only attracted patients that were sort of low clotting risk. And within that subgroup, only 3% were CHADS 5 and 0.5% of CHADS 6. So those are the patients they are really after, that really want to ask the question, do these people need bridging or not? Their endpoints were arterial thromboembolism, so you would think that the people in the bridging arm would have lower rates of this at a cost of more major bleeding. So when you look at the data, the no bridging versus bridging was equivalent. They had similar rates of events. And those patients that had events, ironically, had CHAD score of 1 to 4. And, not surprisingly, the bridging arm had more major bleeds, and this is quite significant. So you'd have to drop your hemoglobin 50 points, or be transfused, or be hemodynamically unstable. So, and the more people in the bridging arm had minor bleeding, so less bleeding than a major. But what about these patients with CHAD score 5 to 6 that really have quite a high annual risk of stroke if they're off their anticoagulation? So given that they have about a 1 to 1.5% per month risk off their blood thinner, and that the study didn't capture these patients, experts conclude that it's just too unsafe, and that the trial wasn't definitive in answering this question, so they keep these patients on this list of who needs bridging. You'd rather err on the side of their blood being too thin for surgery versus the other way around. And what about post-operatively? So again, they asked them to restart their DOAC 1 to 2 days post-op if it's a low or standard bleeding risk. And everything in urology is considered high, and so they start the medication on post-op day 3, with the big caveat being at the discretion of the surgical team, have they achieve hemostasis. I think the big problem is after TUR surgery of the prostate or bladder. So urine contains urokinase, which converts plasminogen to plasmin and disrupts clots and makes them unstable. So what Dr. Peterson recommends, and I think we've all concluded at M&M rounds, that on post-op day 3 or later, some urologists are day 5, that only to restart their DOAC if the urine is clear, and to hold it if they're still having hematuria. And when I discharge patients after a TURP, I tell them they'll expect some blood in your urine for about a week. So that means they must be holding their medication for a week, and it's important for us residents who are, having that discharge discussion that these medications can, cause you to come back with clot retention. So just to restart the medication once their urine clears. So there was a trial looking at this prospectively, just hematuria after a TURP. How long does it linger for, and what rate of these men come back with clot retention? The numbers seemed high to me, but it was the only one that looked at this problem prospectively. So 47% after the first week, their urine is totally clear, and 73% by the second week. And median time is about 8 days. So I'm going to keep that number in my mind as to when you can reliably expect their urine to be totally clear without any hematuria. So let's switch gears a bit. Let's talk about surgery. So I always find that urologists have the perfect blend of optimism and smarts. It's always a frequent discussion with anesthesia about how much or what is in the bucket, I guess. So I found this book online in my dark and lonely nights. And this is a general surgeon from Fall River, Massachusetts, and he wrote a book, and it was called Confessions of a Surgeon. And in it, it said surgeons hate to lose blood during an operation. It adds time, it obscures the anatomy, and it can lead to mistakes. And that he said that excessive blood loss is a reflection of operative skills. So many surgeons tend to underestimate the blood loss after an operation. So given this, how do we keep bleeding to a minimum? So these are tools that we've developed: cautery, clamps, sutures, ties, clips, a finger, sponges, argon beam, ligature. So, it's very highly variable how we use these tools, right? They're all available. They're all in the core or readily available. And it's a product, of our surgeon preference, training, the area of the body we're working in, and nuances of each case that how we navigate the case and attain hemostasis. So you take radical prostatectomy at VGH. How do we keep hemostasis? Dr. Gleave uses primarily, cautery, whereas in an open fascia, Dr. So likes to use clips for the pedicle. Same with Dr. Black. Dr. Goldenberg during a RALP likes hemolock clips and dissects with cautery. And Dr. Black uses a sort of blending of both. So given that, at the end of the day we all achieve hemostasis, it's a product of personal preference and training about how we reach it. But is there any way to exploit the coagulation cascade to perhaps add another tool in our hemostasis toolbox? And these are with the topical hemostatics. We use these when surgical hemostasis is inadequate or impracticable. There's physical agents which promote hemostasis using a passive substrate, and biologically active agents which enhance coagulation at the bleeding site. So it's typically used for peritoneal, pleural, or cut surfaces of solid organs, bleeding near nerves or vital structures, and bleeding from vascular structures or grafts due to suture holes. So a quick review of the physical agents. This is a matrix material that provides a stimulus that activates platelets and the extrinsic pathway and really provides a scaffold for thrombus deposition. We all know oxidized regenerated cellulose, also known as SURGICEL, a bit of gel foam, and then these other three don't use much. Collagen and NHS PEG advanced patch was recently trialed by Dr. Guan, so I do have a slide on this. So SURGICEL, dry absorbable sterile mesh, It can be applied to areas for minimal bleeding. There's new SURGICEL Snow. It's a non-woven structure that has a higher surface area, and it says that they achieve hemostasis quicker than original SURGICEL. And its applications, we've all seen it: lymph node dissection around the neurovascular bundle during partial nephrectomy, or dissecting around the adrenal gland can be very helpful. So the hemo patch is interesting. It's a flexible collagen pad coated on the underneath with NHS PEG. And upon contact with blood and other fluids, the NHS PEG layer is activated and forms covalent bonds with proteins in collagen, blood, and at the wound surface. So it acts sort of as a seal. And these bonds cross-link the pad to the tissue, enhancing tissue adherence and sealing the wound. And the collagen, which the pad is made of, induces platelet aggregation to the surface to support clot formation. So it's used in liver surgery, but I've seen a trial on partial nephrectomy, and recently it's been used in renal transplant around like the sinus of the graft. And then there's biologically active agents, so these augment different parts of the coagulation cascade to achieve rapid hemostasis. So topical thrombin, thrombin gelatin combination, or FLOSEAL, fibrin sealant, and TACOSIL fibrin sealant patch. These agents are more expensive. FLOSEAL combines human thrombin in combination with bovine gelatin, and it requires blood flow as a source of fibrinogen. And one of the warnings is that thromboembolic events if injected directly into a medium-large blood vessel. I couldn't find any urology studies, but I looked into a meta-analysis of total knee arthroplasty and FLOSEAL, and there's no increase in DVT or PE versus not using it. So I've seen this being used in partial nephrectomy, RPL&D, RALT, mini PCNL. Anticial is a combination of fibrinogen and thrombin, so it mimics the final step of the coagulation cascade and requires dry application and can be sprayed. I've seen this used during partial nephrectomy, hypospadias repair, RPL&D, pyeloplasty, and vasovasostomy. So, when you think of the traditional techniques of reaching hemostasis in these new topical hemostatics, these are all the tools we have at our availability to keep the operative field clean. And going forward is sort of dealer's choice or surgeon's preference on a case-by-case basis and what we use to get through it.
Can I ask a question? How many people actually use FLOSEAL? Have you gone back when you have used FLOSEAL? Don't go back. Use it a few times in biopsy of the kidney biopsy for Wilms tumor. You go back, it's like cutting through concrete. So when we had to go back to the nephrectomy on those kids. It was like, and then
I think that would be time dependent.
yeah, it was like 12 weeks. Well, you have to do it at a certain time after their chemotherapy. But if you think that it's going back, I heard that what you can do, you have to make sure that it's not spread all over the place. So from then, and what I've changed is just put a patch of SURGICEL on top of it, so it doesn't go everywhere and to the surrounding tissue.
But ultimately it gets better.
I don't know. I mean, every case that I had gone back in the first 6 weeks to 12 weeks, it was like hell.
It's also an imaging problem post-op too, because you can see it, but obviously on the scans, it's not the biggest factor.
Unfortunately, we're at our summary slide, so I ripped through that quickly. But today we covered the DOACs. We talked how they're a quick onset of action and half-life being 12 hours, and no need for bridging, and that they should be restarted cautiously because they work quickly, and it's sort of point of no return. You got to wait those 5 half-lives if things happen. And And don't dismiss gross hematuria on anticoagulation. Studies will reflect that. We covered the new CCS guidelines that broad indications to start oral anticoagulation are coming for AFib that may affect our patients. And for the complex cases, thrombophiliacs or patients that have high CHAD score or mechanical heart valves, don't hesitate to involve hematology, especially if they're on warfarin and need bridging. And remember your topical hemostatics when looking in your hemostasis toolbox. So I'd like to thank Dr. Guan and Erica Peterson from hematology here at VGH. Thanks.